Good morning and welcome to the YCCI Cultural Ambassador Community Health Watch. Our topic today is new pathways in the treatment of mental health. Our guest is Dr. John Crystal, co-director of the Yale Center for Clinical Investigation, chair of the Psychiatry and physician-in-chief of psychiatry. Amen. And with us also, our co-host is Reverend Elvin Clayton, pastor of the Walters Memorial AME Zion Church in Bridgeport. Dr. Crystal, we're honored to welcome you back to our extraordinary as a guest on our show. We know that you are an extraordinary doctor, a leading expert in this field, and we are just so elated to have you on this show. Our goal is to help our community understand new pathways in terms of drugs that are used for treatment in mental health, its development, and also some of the deeper issues that deals with guilt and shame as it relates to mental illness, particularly post-traumatic stress syndrome and others. And so we're just so happy. So I'm gonna start off by just asking you to just give us an overview of the landscape of mental health as you see it right now.
Well, first, Reverend Perry, Reverend Clayton, it's wonderful to be back with both. It's like getting together with old friends. We've been in countless meetings together and talking about these important issues. So the landscape of mental health is both discouraging and inspiring at the same time. What's inspiring is that over the past 5 years, we've seen more new kinds of medications approved by the FDA for conditions related to mental health than we had probably in the 30, 40 years before then. Fundamentally new kinds of treatments. We've seen depression, esketamine, for treatment-resistant symptoms of depression. We've seen two medications which are very closely related. Zuranolone is the one that was most recently approved for postpartum depression. These two medications were the first medications for postpartum depression. We saw the approval of a drug called lecanemab, which was the first medication for Alzheimer's disease that slowed the progression of Alzheimer's disease. And then just last year, we saw the FDA approval of a drug called Cobenfy, which is a new medication for psychosis symptoms. That's hearing voices, having wild beliefs that you sometimes see in association with schizophrenia. And this is the first medication that is mechanistically different from all the other medications before. And that has the advantage of potentially improved tolerability and freedom from some of the side effects that have plagued the older medications.
You know, Dr. Crystal, I don't think our audience really understands how long it takes these drugs to come to market.
Yeah.
Some of the downsides to these drugs. I remember talking to you about a friend of mine who was taking Thorazine, and he blew up like a balloon, and he was docile for most of the time that he was taking it. I don't want people to think that these drugs come to market so easily and that there are not some side effects or some effects that are with them. And we look at you as the father of ketamine, the ketamine study, because you've been dealing with this for more than 25 years, and you've really brought some groundbreaking work to this. And right now, it's the most popular and most talked about drug on the market. And yet you're telling us today that there are some other drugs down the line that we're moving toward that have even greater benefits. So I'm gonna open up that ballpark for you to go
Sure.
anywhere you like.
Sure. So let's start with esketamine because that's a good way to frame the challenge and the opportunity. So the we by 1958, 57, we had examples of all of the standard antidepressant classes. Most of them were approved by the FDA during the 1960s. And then we had a kind of revolution in the late 1980s, early 1990s, when Prozac was approved, because it was like the older medications, but a little bit more tolerable. And all of these medications targeted two chemical systems in the brain, norepinephrine and serotonin. And they work reasonably well, and they're reasonably well tolerated, but people would say that they had some drawbacks. First, they're slow. So, you have to take them for every day for a couple of months, and to get the full benefit from them. And you have to keep taking them once you're feeling better to continue to benefit from the medications. And another thing is they don't work for everybody. So somewhere around half of people will feel meaningfully better, maybe not all better, when they take these medications. And then they may have side effects from them. For example, sexual side effects are common with SSRIs, and so one of the problems you have with antidepressants that are slow acting is that people with depression are easily discouraged and struggle with hopelessness in their lives. And so a lot of people stop taking the medications before the benefits kick in. And that's a real problem, right? And so one of the things that happened with the ketamine story was that we started testing it for depression in around 1995. And we published the results of the first pilot study in 2000. That's 25 years ago. But it took from 2000 until it took a while for a pharmaceutical company to get interested in the area, and that was Janssen Pharmaceuticals, which is part of Johnson and Johnson, and they developed esketamine, and it took until 2019 for esketamine to get approved by the FDA, and it turned out that was just the beginning of some of the challenges, because there weren't the clinics. The esketamine is a drug that is administered only in clinics, and there weren't enough clinics around the country to deliver the treatment. But esketamine is really an incredible game changer, and we're gradually getting more and more places around the country that can deliver esketamine and ketamine as treatments, and that's a really wonderful thing, because it works really fundamentally different than the older antidepressants. First, if you have treatment-resistant depression and you get a dose of ketamine, you have a pretty good chance of starting to feel better after that first dose of medication. People will sometimes get continued improvement with additional doses, and when you start the medication, you start it twice a week, and then over time you maybe switch to once a week, and then less frequently after that. But unlike the older medications, you don't take it every day. You just take it sporadically as the doctors recommend. And the second thing is, as I mentioned, it's possible that you may feel better as rapidly as within hours of your first dose, so that kind of rapidity doesn't occur for everybody. The second thing is that if you have treatment-resistant symptoms, let's say you've been on one antidepressant, it didn't work. They added another medication, it didn't work. Maybe they switched you to a different medication and it didn't work. Maybe they added another medication, it didn't work. That doesn't mean that you won't respond to the esketamine. In fact, esketamine is about twice as effective as any other medication for patients who have these kinds of treatment-resistant symptoms. So that a lot of people who have been discouraged about the possibility of getting better from ketamine, better from their depression, have been surprised when they've had a good response to esketamine. And people write to me from around the country and sometimes around the world to tell me their stories about their own struggle with depression and the importance of keeping hope, keeping hope alive that there's a good treatment that'll work for you. And for some people, that's esketamine. A second thing is that ketamine also is very good at protecting people from relapsing to depression once they've gotten better. So what's often not appreciated is that if you respond to a drug like Prozac, it's nothing in particular about Prozac, but just using it as an example, and if you have these treatment-resistant symptoms, then there is some significant likelihood that you'll have some breakthrough symptoms after you've already responded to the medication. And those breakthrough symptoms can be very discouraging after it's taken a month or two to start feeling better. And then 6 months later, you feel like you have some of your depression back. Well, it turns out that compared to standard medications, that esketamine reduces the likelihood, probably by about half, of having those breakthrough symptoms. And then there's some other effects of esketamine that are kind of striking. One is that in long-term treatment, these are data that Janssen had collected, on average 42 months of treatment, that if you are treated with esketamine on top of your usual treatments, compared to just standard treatment from historical data, that ketamine reduces the chances of attempting suicide, it reduces the chances of dying by suicide, and it reduces something called all-cause mortality, which has to do with something that the three of us have discussed before, which is that we have to approach depression with the seriousness that we approach cancer or heart disease or other kinds of problems. It turns out that inadequately treated depression shortens life expectancy by about 10 years. That sounds a bit like what cancer and heart disease and other kinds of treatments do. And standard antidepressant treatment, more effective treatments for depression, reduce some of that shortened life expectancy. But even in comparison to standard antidepressant treatments, ketamine reduces the shortening of life due to the way that depression, being a whole body disease, affects your heart, affects your lung, affects your kidneys, and your cerebrovascular system. In other words, the risk for strokes. So by reducing the added burden on your body that depression creates, ketamine has an effect on your life expectancy. So these are, to me, pretty remarkable and transforming kinds of things. And so we're really glad that, we have at Yale New Haven one of the first clinics that delivered ketamine and esketamine in the country, and one of the more active clinics.
Dr. Crystal, go ahead, Doc.
Before, yes, this esketamine, do most insurances cover a patient that they can receive this medication? And if they don't, are there ways in which they can be helped with it?
Yeah. So both private and public insurance mostly covers esketamine now. It took a little bit of time after the FDA approval in 2019, but Medicare and Medicaid do cover esketamine. It's true that the hospital doesn't make much money when it's Medicaid, because the reimbursement to the doctors in the hospital is not great. But that's not what counts. What counts is getting effective treatments to as many people as possible. And so, yeah, I think the access, other than there's sometimes a waiting list to get access to it here in New Haven. But other than that, I think that people should be able to get access to esketamine, which is almost always covered by insurance. Yeah.
And now, if the person doesn't have insurance, is it possible for them to get it, or how expensive is it?
Yeah, I don't know the answer to that question. I assume the answer is yes, and it varies by where they go to get the treatment. So, yeah, the cost of it. I mean, it has to do, the varying costs have to do with how big the staff is, how like et cetera, et cetera. That's why it varies a little bit from some bigger and smaller clinics.
I was going to say, Dr. Cristo, that the success of any drug also brings to the public the idea that that it is so good, it can be used for recreational purposes. I mean, it's that good and it works that well. People try to circumvent the professional use,
right?
And they say, well, if it's going to make me happy, if it's going to make me feel good, if it's going to deal with my depression, I don't have to go to Yale New Haven. I can just go to what you referred to once as the man.
Okay.
So, right. But there are dangers there. You want to just kind of tell us about that?
Yeah, we in the medical profession have to be really careful about how we talk about these new medications with the public. And that's one of the reasons that I really appreciate the opportunity to join you both here today, which is, first, I think of a treatment like ketamine as an intervention that's embedded in an overall treatment. An overall treatment, it means that somebody's looking out for your overall well-being and thinking about the overall plan of what your treatment's going to be looking like. And so maybe you have psychotherapy, maybe you have some rehabilitation, maybe you have some other kinds of activities that are designed to help you get engaged. And most people who are getting ketamine or esketamine treatment stay on their older antidepressants, and the esketamine is added periodically on top of it. So esketamine isn't the treatment. Esketamine is an intervention that's part of an overall treatment. And that's one way that taking it by yourself is different than taking it, as part of treatment. The second thing is, and this is really important to understand about esketamine and ketamine, which is that it works in a very only at a particular dose range. If you take too low, it doesn't work. If you take too much, it also doesn't work. If you take too little, you get a buzz. And so it's like a glass of wine, a couple glasses of wine, or glass of beer or whatever. And people like that buzz feeling, and they feel a little bit more relaxed, and they think they're getting a benefit of the drug. But that buzz, that high, just encourages people to use more and more ketamine. And one of the reasons that we don't want people to use it at home is because even if you don't take an effective dose of the drug, you get a little bit of relief. And so I've seen people who have used it, 6 times a day. And I've traveled to places where they have a bigger ketamine abuse problem, and there are some people who are heavy users of ketamine who will use 100 times the clinical dose of ketamine, 100 times the antidepressant dose, and they don't look better. They don't look less depressed. They look more depressed, and sometimes they're even may look more like they have schizophrenia. And so the dose has to be really carefully regulated in a context embedded in a treatment that's looking at the overall well-being of the patient. You know, we all know or I think most people know of the sad story of Matthew Perry. Yes. And he was someone who took too much ketamine. He had a ketamine use problem, and he took too much. He took enough ketamine to anesthetize him. Ketamine was initially developed as an anesthetic medication, and he took enough ketamine to anesthetize himself while he was in the bath, and he drowned. And so, you know, these medications are not just because they're used for treatment doesn't mean that they're safe in all contexts, doesn't mean that they're always effective, and doesn't mean that they don't carry risks if not used in exactly the right way with the right kinds of protections in place. And so I'm really glad that you raised this point, because we have seen in this country an increase in recreational use of ketamine, maybe self-medication, since 2019 when ketamine was approved.
So people who are using recreational drugs, how does fentanyl end up in some of these drugs? I mean, why would a person alter this with the risk that and you know, we're still trying to figure out where the fentanyl is coming from. How do we get it? How do we put it into, you know, the community?
Right.
We saw what happened on the Green. Remember when all of that we had that massive
K2
overdose? That was ridiculous.
Right. So this is one of the problems with illicit medications. You never know what you're getting. You never know really exactly how to adjust the dose. So the time on the Green was an extraordinarily potent synthetic version of cannabis came out. It's called K2. And so people were just dropping. They would just take a little bit. They had no idea what the right dose was, and they would just fell unconscious on the Green. That there was at least one case of somebody who took a little bit of the drug, was unconscious, brought to the emergency room, was kind of sustained until he perked up, and then he went back to the Green and did it again, and had to go back to the emergency room a second time in the same day. And so obviously, I think a couple of things. Number one, obviously, there's a lot of pain. There's a lot of desperation. People are looking for a quick way to feel better, and that's, you know, sometimes what they need is treatment for their anxiety, for their depression, for their hopelessness, for whatever it is that's going on. There are people there who can provide help, who can provide support, and give you good ways to kind of get better, as opposed to these risky ways. The second thing is that these examples of the person who goes back and does it again, it clearly out of control, right? Their drug habit is so strong that the habit is driving their life choices, as opposed to any kind of more balanced decision-making process. And, you know, trying to understand this process, habit, how do we develop habits? How do we change habits? Habits are the hardest things to change, because these are primitive, almost mechanical, you know, we share our propensity for making habits, you know, with worms and mice, and you know, we're in some ways the most elaborate machines of the universe, in some ways shockingly primitive. And most animals are kind of driven by habit, and we can fall into that. And really experience ourselves as being out of control. That's one of the reasons that getting treatment for addiction is so important, because people think, well, I'm on top of this, I can control it. And then they get into a situation where they're with their friends, they're with the reminders, they're in those same old places, and it's out of control.
But Dr. Crystal, when we talk about habit, they're good habits people have and they're bad habits.
Right.
So it seems to me that the hypothesis is what's beneath the habits that drive them in that direction and keeps them there.
Right.
And you had mentioned to us something about when we were talking about PTSD and guilt and shame, which is the field that Reverend Clayton is most most familiar with in his work as clergy.
Yeah.
Original sin, and saving souls and making people feel happy on Sunday morning. But there is it seems to me, a deeper psychosis here that goes on in terms of the subconscious mind. And as a psychiatrist, I'm wondering how, we talked about it before, meaning.
Right.
Is it the meaninglessness in our, not Camus or Sartre, but in the meaninglessness of our understanding of reality that brings us to the point of desperation, where we look for these rainbows of hope anywhere we can find them, and then once we catch hold of something we think is good, the habit makes us continue as if it is the ultimate cure, and it's not.
Yeah.
It's a pseudo.
Yeah. Meaninglessness seems to be a core challenge. Desperation, meaninglessness, guilt, shame. These qualities are really things that just undercut our ability to keep going, right? And one of the things that as you point out, is that when we can't find things to connect to, when we can't find people to connect to in positive ways, that shame and despair often drives us to do things into connections that are not so good. So I want to come back to something that you said before, which is that there are good habits and there are bad habits, right? And that things that bring us together, things where we can work towards on issues that are bigger than us, where we can find meaning and find purpose, positive purpose. These are some of the most important ways that people keep going. And we've talked before about Viktor Frankl and his critical work, and Viktor Frankl quoted the philosopher Nietzsche, who said, in a sexist way, but okay, he who has a why can endure anyhow. In other words, no matter how bad things get, if you know why, what you're working for, you have a sense of purpose, you have a goal, you can endure almost anything else that you need to deal with in your life. But if you lose that sense of meaning, and you have no feeling of purpose or possibility of having an impact, then you can have wonderful things around you. You have wonderful opportunities, but you may not be able to take advantage of them. And this is one of the things that has come up a lot in the discussions about the development of psychedelic drugs in the treatment of psychiatric disorders. And when I talk about psychedelic drugs, I'm really talking about drugs like psilocybin, which is the best studied drug. But there are other drugs in this class that people may have heard of. LSD, which is not very much used in psychiatry research because it's very long acting. And then some short acting cousins of psilocybin called DMT or 5-methoxy DMT. And these drugs have one of the striking things that comes up when people use them in treatment, not at a rock concert or at a Grateful Dead performance necessarily, but when they use them in treatment, is they where they are prepared for it appropriately, and they have sessions afterwards to make sense of the experience, is that people often describe these treatment sessions as not only alleviating some of their symptoms of depression, which is often what is the focus of the clinical research on psychedelic drugs, but also that they had a very meaningful experience, that they felt much more connected and found meaning and so when these drugs are used to treat addiction or to treat depression, it's sometimes this other aspect, this positive quality of the treatment experience that has been very important to them. They've, in a way, found meaning through pharmacology. What people who are old time experts in this area have told me is that you can often get to the same place around feeling about meaning and connection through meditation or through other kinds of experiences as you can get pharmacologically induced, but you have to work at it, right? You have to work at it for a long time and develop a broader perspective. Whereas the treatment, when these drugs are used as treatment, I think they're a way of accelerating not only the recovery of the depression, but dealing with some of these issues like guilt and shame, which can sometimes be lasting burdens of trauma that you've experienced in your life, or other kinds of issues that you've experienced.
Yeah, you said about guilt and shame, how some people will not forgive themselves. Like if they've been raped and they just think, well, I should have done this or could have done that. And I like the whole thing about the MDMA that you was telling us about, how it opens you up to be less guarded and more open to people and relationships, which is a curse in one way and a gift in another way, because people can take advantage of you. You want to talk to us about that MDMA and the study of how that had to go through a number of processes because foundations took it, they didn't know anything about research, and yeah.
Right, that's exactly right. So we're talking about a drug that's sometimes called ecstasy, but has the chemical name, it's a really long one, rolls off the tongue, methylene deoxymethamphetamine. And it's obviously by the name a derivative of amphetamine. It's not a psychedelic drug. It's not a ketamine-like drug. It's its own class of treatment. It does not produce hallucinations. It was developed by a foundation called MAPS, which was founded by a guy named Rick Doblin, who we actually collaborated with in the late 1980s to try to study the effects of MDMA use on the body and the brain, and here at Yale. And anyway, so they tried to develop MDMA, and they were able to support some studies which had some limitations relative to getting the drug approved by the FDA. But the studies did provide some encouraging results related to the ability of MDMA to treat symptoms of PTSD. Mm-hmm. Now, I watched a number of the treatment sessions from that study. They were videotaped. I didn't participate in that study, but I did watch some of the videos. And as you say, one of the striking things about MDMA is that it makes you feel connected to people around you. So it makes you less mistrustful, less defensive, less ashamed.
Mm.
you know, around people, so people feel very sociable, very connected to people around them, and
And
that's
they are more trusting.
more trusting, right? And so I, when I first became aware that MDMA was being tested for PTSD, I wondered, how does a drug that makes you feel more connected to other people, more trusting of other people, more forgiving of other people, how does that work to help you manage your own symptoms? And I thought that maybe it would be used in couples therapy. And in fact, one of my colleagues at the one of my colleagues did a study where they used MDMA to facilitate couples therapy for PTSD because it helped to break through some of the defensiveness and some of the kind of irritability and that made couples therapy sometimes difficult. But when I watched the sessions on the videotape sessions, what I was struck by was that MDMA kind of helped someone to have the same effect in the way they thought about themselves. So rather than being so judgmental and critical about themselves, they were able to cut themselves some slack. Rather than being so defensive. So, so one of the things that happens in PTSD is that thinking about the trauma and its aftermath is so painful, shame, guilt, anxiety, that people don't want to think about it. And so it can be very difficult, sometimes overwhelming, for people to talk about their trauma experiences, even though they know that at some point in psychotherapy for PTSD, you're going to need to come to terms with those experiences that you have. Well, people could seem to be able to talk about their experiences, to be a little more forgiving of their of themselves, to be able to be a little less ashamed of what they'd gone through, a little more understanding about what they'd gone through. And so, beyond whatever beneficial therapeutic pharmacologic effect that this drug was having for their PTSD symptoms, I thought it looked like it might help to make the psychotherapy of PTSD more effective by uh, helping them to have a different perspective of themselves and their experiences.
Yeah, that's awesome. And you have a friend, Kevin Ryan, who is working to use this drug to produce this at Yale?
Right. So this is he has created a company to develop a cousin of MDMA
Right.
called methylone, and they're developing and they're generating some very interesting data with methylone for PTSD. And they are more traditional pharmaceutical companies, so they're doing all the
Right.
studies. I mean, some of the issues that the company called Lycos that was developing MDMA ran into had to do with what seemed to be like potentially avoidable problems. In other words, if you develop a drug and you say it needs the psychotherapy to be developed,
Mm.
then the FDA requires you to show what the drug does by itself, what the psychotherapy does by itself, and they require you to show that the drug and the psychotherapy are better than either one alone. And Lycos never did that. And there were other challenges that they faced, but those big challenges, that's not going to be a problem for Mr. Ryan's company, because they're approaching it in a more traditional way.
But see, I think that's important to note that, in bringing a drug to market, you have to have some ethical guidelines. You can't coach the people in the study to say what you want them to say in order to get the drug approved, and you can't take shortcuts.
Right.
And I think that's important for people to know that when these drugs really come to market, they come correct. And you can't these because these shortcuts and a longer and a longer reach or range may have wicked effects.
Right. You know, and this is we're not very patient, and nor should we be, right? Because we're talking about treatments that are treating life and death problems.
Right.
On the other hand, we want to be assured that when a drug gets approved, that it's not going to be harmful, that it's going to do what it says it's going to do. We want to know that it's safe because people are going to be taking it for years. We want to know it's effective because it's going to cost a lot of money to deliver these treatments. And so we don't want to waste people's time. We don't want to delay them getting to effective treatment. And so we need this infrastructure to hold the line, basically, to make sure that the medications that are available are safe and effective. So it meant that the company, Lycos, had to go back to the drawing board and do some more studies that would address the FDA concerns. And once they do that, I suspect they'll get approval for MDMA as well.
Reverend Clayton, do you find that there is a stigma in the church and in the community with regards to mental health? And how might we deal with that?
There is, but it's improving.
Mm-hmm.
And I say it's improving because it's because it's more known now. It's a popular thing. Athletes and actors have come out and shared the fact that they have struggled with mental illness. And so it's not as hard as it once was. And another thing, when we're talking about mental health, I'm wondering, Doctor, if we would listen to people early on at the first signs of an issue, that they might be better off, or they would be better off. Church is a good place because that community, the right hymn, the right prayer, the right sermon, it lifts people to a place where they was not, before they entered. And sometimes without that connection, that spiritual connection, it causes more problems. Then they have to rely on medication and things to help them through.
I have a question for you, Reverend Clayton. Why do you think it's been hard? What makes it hard? Is it that people feel ashamed of having symptoms, or do they feel that people will think less of them? What is it that gets in the way, like in the church, of people admitting that they have problems that need help?
Number one, I think some people are in denial that they have a problem, number one. Number two, people are private. And no one wants to be labeled as, in the old days, it's crazy. Mm. We don't use that. We don't say that now, but that's what it was in the past. People don't want to be labeled as something. But like I said earlier, it's getting better because more and more people are talking about it. This show is one avenue that's going to help people who may have the problem, or they know someone with the problem. These are things that help people come out and say, look, I need help, without someone have to telling them that they need help.
Something you said resonates a lot with me, which is that one of the things that has happened as we have understood mental illness a bit more is that we don't mix up the person and the problem. In other words, like, I'm a person who is managing anxiety. I'm a person who is managing depression. I'm a person who's managing trauma. I am not depression, right?
There you go.
I'm not crazy. That's not who I am. I am the person that's on the other side of this, that's going to get to be better.
And I'm the same person that has cancer.
Right.
I'm the same person that needs a knee replacement.
Right.
I'm the same person that have whatever. That's it. That's where the rubber meets the road.
Well, see, I think that biblically, and from our Judeo-Christian understanding, shame is the one word that we deal with. Is shame, and that shame makes us feel guilty, and also it keeps us from wanting to share that shame with anyone because it's embarrassing. And I think that what psychiatry has done is that in terms of labeling people, it has just worsened the problem because now you're labeling a person as psychotic or schizophrenic rather than dealing with whatever the issue is with the person. You've labeled them, and so now you compounded the whole treatment process.
Right. So I deal with this issue all the time, which is first that the labels that we use in psychiatry, we know they're provisional and will evolve over time. Second, that people on the one hand need a way to talk about what's going on. They need a frame of reference, and so we have to be careful about how we use labels. Oh, right, we always have to. So I can tell you how I use labels. So, and which is the way I use labels, these diagnoses, is to come to a shared understanding with the person that I'm talking to. So I say to the person, so you tell me what you're experiencing. And they say, I hear the voice of the devil yelling at me all the time. Okay, what else? I feel like the FBI is following me wherever I go. I walk into a room and people look at me, and they look at me like they know me already, even though I know they don't know me. I say, okay. And then I say, what else? And they say, well, I don't have much motivation to do things. I'm kind of a loner. I say, okay. And they'll say, okay, what is that? and I say, all right. I say, you and I, we're going to come up with a term for it. We're going to call it schizophrenia. And what that means is that you hear a voice, that you hear the voice of the devil. It means that you have these fears and these strange feelings that don't entirely make sense to you. And we're going to use this term to talk about it because by giving it a name, then we both know what we're talking about. And when I give you a medication to try to help those symptoms go away, we know what we're looking for to change. Yes. And that I find is a way to get around some of this labeling that is harmful, because it can be harmful, as you say.
We have about 2 minutes left. Harry just sent us a note.
And you want to announce that we're listening to 103.5 WNHH New Haven Independent, and we are sponsors for our show. All right. So we got 2 minutes. Dr. Chris, do you have any final? I know we got so much to cover, but I think we did a good job today. Do you have any final comments you want to leave with our audience?
Sure. First, just to say, Reverend Clayton, Reverend Perry, it's always a pleasure to hang out with you guys and to talk. And I think we just scratched the surface today, so we'll have to do this.
Just a scratch. Just a scratch.
Yeah, because one of the questions I wanted to ask, and I know we're going, was like for the new drug that we're talking about, the MNA.
Right. MDMA, yeah.
MDMA. How does that administered?
That's a pill.
Okay.
That's a pill, and the psilocybin is also orally administered. administered like a pill.
So psilocybin is like mushrooms,
That's from the mushrooms. That's right. From the
Right.
psilocybe
So
mushroom.
there's so many stores now in Connecticut. You can just go in and get something similar or less.
Well, it's not legal to buy psilocybin. Cannabis you can buy, obviously, but psilocybin is still an illegal drug. Yeah. Oregon briefly legalized. They briefly made it legal to have mushrooms in Oregon, but I think they turned it back, made it illegal again.
Wow.
It's one of the issues that you see with psychedelics, which medically are generally in limited ways can be safe, but in the clinical trials of psilocybin for depression, there were people who became more suicidal after the exposure to the drug.
We think Harry's about ready to play the music. Dr. Crystal, you are special.
Right, we
have to come back and talk about that.
We'll save this for next time. This is a teaser for when we come back next time.
Yes. All right. Thank you again, Dr. Crystal.
Okay, my pleasure.
We appreciate it.
You're listening to the Community Health Watch Show on WNHHLP 103.5 FM, your home for community radio. Stay informed, stay connected, and take charge of your health. We'll see you again next